Setting things up, I'll introduce Fernando once again. He's an endowed professor in medicine, the Campbell Chair, which is very appropriate to being in the Campbell Auditorium. Practicing pulmonologist, critical care physician at the University of Colorado, the Angeles Medical Campus. Fernando went to medical school in Mexico City, did his initial college training at Emory University in Atlanta, pulmonary critical care medicine. Spent time at the Center for Disease Control, which he had a chance to speak a little bit about earlier this morning, and went to the University of Pittsburgh, worked with Sally Wenzel in asthma clinical trials and airway epithelial cell biology. Then moved about 8 years ago, Fernando, to the University of Colorado, where his research is focused on air pollution, associated health effects, translation, clinical trials in asthma, and as we'll hear in the next talk, metabolism and how it's important in asthma. Fernando also informed me he's been appointed about a year ago, the division lead for pulmonary critical care at the University of Colorado. It's a big job. It has divisions of more than 200 faculty. There we are. Now, there's a challenge.
I used to have hair when I started.
And we're delighted time to travel up to join us here at Firestone, and I'll hand over to Fernando to present the research presentation.
Thank you, Paul.
Thanks again for the invitation, and thank you, Victoria, for helping me with my talk and travel. You have to put those of you who were here before, you have to put it with me again. This is going to be a very different talk, so hopefully you'll get something out of it. But it's about an area that's been sort of deep to my heart for a number of years. So I'll give you a little bit of flavor of how I've gone into understanding some of these phenomena from a clinical and translational point of view. So what I hope to talk to you today is how obesity and metabolic dysregulation impact asthma. And then talk about clinical phenotypes and endotypes that are associated with obesity and metabolic dysregulations. And then I'm going to talk about some novel mechanistic pathways that lead to inflammation, metabolism, and asthma. It's an area of active research in my group. And then highlight some potential new therapeutic strategies. When I was at the CDC, this is one of the earlier works. People were starting to understand that there was something about people with obesity and asthma that they did worse, and people initially thought it was just confounded like symptoms. And over the time, we've known that there is in fact some real implications to the airway function and the airway biology. But here's one of our early works at CDC, just showing that using the 3,000 patients and adult patients on the National Asthma Survey, compare obese to overweight or normal subjects, people with asthma or obese have symptoms all the time and are more likely to be classified as severe by GM. And this is being replicated in many different studies. But that, to me, this paper set the stage. Is like, as a researcher, as a clinician, like, I want to know why obese subjects with asthma are sicker. So I'll just go through a few key studies to illustrate that how it really involves many aspects of care. This is a retrospective pool analysis of 1,500 patients from different studies that were randomized to fluticasone and salmeterol. And you can see the weight distribution here. Most of them were over obese, and some of them were obese categories 2 and 3. But clearly shows on the right side that the more you move over into a higher BMI category, the less likely you are to experience an FEV1% after 3 months of treatment with lethal corticosteroids. This is one of the first studies that showed that obese asthmatics are less likely to respond to lethal corticosteroids. And this has nothing to do with symptoms, right? This is a lung function test change. But it involves other treatments. This is a pooled analysis from Sandy Kurana from Rochester. 5 phase 3 studies that were evaluating the effect of tiotropium, LAMA, on asthmatics of mild, moderate, and severe. And what I want you to point out, this is a change in FEV1 peak levels after treatment. You can see that as your BMI drops, your peak response to tiotropium is lower. But in the throat, this is sort of the average response to the study was a lot less clear, but you can see a trend towards less response for tiotropium, although there were also of a higher BMI. The blue lines are the severe group, which you did not see on the people with milder disease. And we recently published this study with Megan, who's a junior faculty in my group, and Mary Forno, who's now used to be at Pittsburgh, but now is in Indianapolis. It's a nice review on the biological aspects of asthma and treatment. But we looked at all published studies on biological therapies and found that there are some studies in which there's a negative implication of having a higher BMI in response to biologicals, particularly when you look at factors like remission or being a super responder and rate reduction. So if you look at the UK severe asthma registry, Paul and I were talking about this last night. If you look at this particular definition of asthma remission, which was like to have an ACQ less than 1.5, no exacerbation for 12 months, no oral corticosteroid maintenance, and a lung function that's preserved compared to pre-biological times, only about 20% of people in the UK registry meet this criteria for remission with biological therapy. But what's interesting there is if you look at what are some of the covariates that are associated with achieving remission, one of the factors that almost impacts very dramatically, I would say almost 60%, you're less likely to achieve remission if you are obese, as you can see here on this forest plot. And also females in this particular study were less likely to achieve remission. So in addition to obesity worsening the respiratory symptom burden, is there a specific obese asthma clinical phenotype or endotype? Is there something like, there is an obese asthma? So I want to give you some data that shows pro and against, and you can make up your mind. Haldar from Europe, in my view, was the first study that came right before the SAD phenotype studies, where they were looking at different cluster analysis to understand these two studies that the cluster revolution in asthma, if you will. Here you can see that what we see clinically is that there's a concurrent disease, right? We have people with benign asthma all the way to severe asthma, most of them early onset atopic asthma, in which there's a correlation between how much eosinophils you have and how much symptoms you have. But then there are other groups, and here I highlighted the obese non-eosinophilic. This is one of the first studies that showed that there was a cluster of people with a higher BMI that end up having a lot of symptoms but were less eosinophilic. So if you look at here, that cluster two was people that had the highest BMI, low T2 biomarkers, had a normal FeNO, lower sputum eosinophils, but yet were very sick. They had a lot of steroid medical throughout the years. And this was also replicated in the SAD phenotypes that we did a long time ago, where you can see this age of asthma onset and level of FEV1 impairment. What you see probably in practice is that many people develop the disease early in life before adolescence. And most of these patients have mild to moderate to severe allergic asthma. Eosinophils play a major role here. But then we have these people that develop the disease later in life, and the obese and COPD-like phenotypes are over here. So for SARP, this late onset of this cluster were also predominantly female, low T2 biomarkers with low atopy, but yet exacerbated quite a bit, right? So very similar experiences both in the US and Europe. But one of the things that I find fascinating is that none of the phenotypes, and this also includes the obese late onset phenotype, is really defined by a particular inflammatory cell type. Right? If you look at here, this clinical, this group 3, it's a mix of different things. It's postgranular, it's eosinophilic, it's neutrophilic. So it's not a particular type of inflammation. UBioPrep went a bit down in their omics analysis in sputum to do a 4-cluster solution. And so they come up with one of the 4-cluster solution in UBioPrep was phenotype 4, which the majority of them were females, had adult onset asthma, lowest FeNO, again, that comes across in all these phenotypes, 26 parts per billion. And their airways, based on omics analysis of the sputum, were differentially enriched by interferon gamma, interferon alpha signaling pathways. So in a way, these patients are more T1 polarized, which I'll show you some information about, and interferon gamma seems to really come across all the time. In more real life, the ISA, which is the International Study of Asthma Registry, which has over 1,100 people, and I think they recruit worldwide. I don't know if they recruit here. They certainly recruit parts in the US and Mexico and other places. And so one of the largest clusters, you can see in red, in the cluster paper that recently was published, is this older symptomatic obese female. So it's a 61% female with relatively low T2 biomarkers, normal FeNO, but very high exacerbation burden. So I've shown you now multiple cluster studies, but they all seem to point to the fact that there's an obese, late onset, female predominant, lower normal nitric oxide, low eosinophilic phenotype. That tends to be very, if you think about it, if you have low T2 biomarkers and you think that those things maybe potentially tell you who's responding more or less to therapy, these individuals are not going to respond to steroids. or less likely to respond to steroids. And this is one of the stories that Sally's group used with SARP with Waywood, looked at a cluster. So when we were in SARP, people came in SARP-3, and we gave them an injection of triamcinolone, 40 milligrams of triamcinolone intramuscularly one time. They underwent a full assessment, phenotypical and endotypical evaluation, and then a week later, or 2 weeks later, were assessed again. And so this analysis looked at what are the cluster responses to receiving a shot of triamcinolone. And there was a cluster solution. Not unexpectedly, cluster 3, which was the highest sputum blood eosinophil, did the best. They showed the most increase in lung function. But look at cluster 4. Cluster 4 was adult onset, obese, with an average BMI of 37.7, at the lowest nitric oxide. It included people that were very sick. Not only did they not fail to improve, they did worse. So cluster 4, if you look at this, is the change in maximal FEV1, the delta before and after treatment with steroids. Those in this group 4 lower their lung function, both in FEBC and FEV1. And this is what I see in clinic, that some of these patients that have no T2 biomarkers, that are adult onset females, don't respond well to steroids. Now, in real life, the story is very different. This is a story that we just published with 70,000 patients with an asthma diagnosis from the UC healthcare system. So this is healthcare data study, where you can see here, this is the absolute eosinophil count in blood of the 70,000 patients. And this is the normal of time, the number of times that these patients receive oral corticosteroids for asthma exacerbation. So you can see there's a beautiful correlation between your eosinophils going up and you're more likely to exacerbate and require oral corticosteroids. But this is very surprising to me, is that when you look at male and female, we saw that females with high eosinophil burden were the ones that were more likely to exacerbate and receive oral corticosteroids. It's a little bit of a different story what I'll be telling you. So just to highlight the fact that these are very complex phenomena. But there is in fact a modifiable effect of an association between eosinophils, as you can see here, and the number of oral corticosteroid bursts in male and females. Females seem to do worse. And also if you look at obese men and obese females do much worse than obese men by eosinophil and exacerbation. So it's an effect modification there, which is very interesting by the way. So the next question is, are there metabolic factors associated with obesity that could be playing a role in asthma? And I'm going to go through some different metabolic factors. The HUNT study is it's a very large European study with 23,000 patients that they were at the beginning of the study were asthma free. So it's an incident asthma study looking at the effect of metabolic factors on these patients. So what they found is that patients that had greater waist circumference were about 50 times more likely to develop asthma de novo. And those that had elevated glucose or diabetes also were more likely to develop asthma during follow-up. This is adjusted for a number of factors. In this study from Cardia, it's a longitudinal study, 4,600 patients done by my good friend Akshay Sood in Mexico, found that women, abdominal adiposity, elevated blood pressure, and impaired glucose or diabetes were associated with about 50% increased risk of developing asthma as a new diagnosis in women, but not in men. So you start to get the picture that in women, for late onset disease, metabolic factors are important risk factors for developing asthma, or for worsening asthma for that matter. In this very large cross-sectional study in Paris from 121,000 men and women, looked at different factors that relate to metabolic syndrome and whether or not they were associated with lung function. And here you can see that glucose, abdominal obesity were associated with having FEV1, both FEBC below the lower limit of normal. And that happens in children as well. This study by Giovanni Filmon, who Paul knows well, he's a pediatrician. This study when he was in West Virginia looking at a large group of kids, 17,000 children in schools, and looking at how factors that relate to dyslipidemia as a marker of metabolic syndrome in children, and whether or not they would be associated with asthma prevalence. So you can see here that, for example, having a low HDL is associated with higher prevalence of asthma in red, and having high triglycerides associated with higher prevalence of asthma. but also children with acanthosis nigricans. Remember acanthosis nigricans from the pediatric studies when you get this blackening of the skin folds associated with metabolic disturbance and diabetes, associated with a higher asthma prevalence as well. More recently, Sergey Bernikov, who now we were lucky to recruit him, he's now in Northwest Colorado, showed using the inspired in Vanderbilt that those with kids with a higher glucose and insulin ratios, so suggesting they have some insulin resistance, are more likely to exhibit recurrent disease at age 2 to 5. So these things affect both kids and adults. It affects wheezing, it affects asthma incidence, and it's associated with greater asthma prevalence. But these things don't happen in isolation, if you will. This is a cross-sectional study from NHANES from Eric Forno in 12,000 patients that shows at the bottom of your graphic that if you're in the highest strata of insulin resistance, it is driven by those that are also obese. So yes, you get a share of people that are overweight and lean, but it's a combination of being obese and having insulin resistance that's associated with asthma at the end. This is from our group. We have a biorepository of patients that we do research bronchoscopies on. We looked at HOMA, which is an index of insulin resistance, and you can see that here there's no relationship between FEV1 and HOMA. There's a very clear inflection point once you start a HOMA of 3, which means moderate insulin resistance, in which the greater insulin resistance you have is associated with inverse lung function. And again, these things don't occur in isolation. This is a PCA plot, principal components analysis that look at multiple factors in our biorepository patients, showing that obese asthma, lean asthma, healthy, they're separated by these factors that explain some of the variability in each group. And if you look at the obese asthma, some of the factors that explain why the obese asthma are in the upper right corner is because they have problems with hypertension, greater BMI, greater waist to hip ratio, and triglycerides. All of these are the factors of metabolic syndrome. So factors that relate to metabolic syndrome associate with obese asthma. And as we recently published in CHEST, having a greater insulin resistance is inversely related to forced vital capacity adjusted for weight. So this is not obesity related. And in one of our cohorts, we had a cohort of obese asthmatics that we follow people for 18 months, adult asthma, mostly Hispanics and Blacks, that we recruited with Mount Sinai and Colorado. And so what you're seeing here is a change in log insulin and the change in asthma control. So in the left of your screen, those individuals during the cohort study whose insulin increased were more likely to experience loss of asthma control or poor asthma control, and were also more likely to achieve poor asthma quality of life. So again, this is the only longitudinal study published between asthma control and insulin so far, but clearly shows there's a relationship adjusted for BMI and other factors. And SARP found something that was very similar. This study from SARP-3, a study from Michael Peters, where they looked at what is the relationship between lung function and loss of lung function with different degrees of insulin resistance. So on the left side of the screen, where you're looking is HOMA categories, so mild, moderate, and severe insulin resistance. And here showing that those people with severe insulin resistance are less likely to achieve maximum bronchodilator, reversibility in testing. But if you look at that, this is the FEV1 change over time of 5 years in SARP. And clearly those that have moderate to severe insulin resistance lose function at a much steeper rate than those with no insulin resistance, which is incredible. Because we normally don't think about insulin and insulin resistance as having anything to do with lung function. But in fact, it does quite a bit. One of the things that I was very interested in is trying to understand how could you potentially differentiate what is obesity and what is metabolic factors to asthma control. And so to ask that question, we looked at the longitudinal assessment of bariatric surgery, which is a multi-center, big NIH-funded study where everybody that went bariatric surgery by choice, not randomized or anything else, so it's a true world study, those individuals were evaluated. So we looked at almost 500 people that also had a concomitant diagnosis of asthma, and we asked the question, what happens to their asthma control after they undergo bariatric surgery and lose a ton of weight? So I'm going to walk you through that story, which is very interesting. So what you see here is that about 80% of them have metabolic syndrome at the beginning of the study, and then by year 1, which is when they lose the majority of weight, and throughout the study at 5 years, the metabolic syndrome was almost gone, but not entirely. About 40% of people still had some level of metabolic syndrome criteria, because remember, this is something that used to confuse the heck out of me. Obesity is not part of metabolic syndrome. It's abdominal girth, right? So you cannot be obese and still have metabolic syndrome. But look at what happened to metabolic syndrome biomarkers, right? So the abnormal HDL corrected, the abnormal triglycerides corrected, their hypertension got better, the glycemia got better, and the waist circumference improved, but only to a bit. They still remain quite a bit large waist circumference. So then we asked the question, well, what happens to asthma control, whether or not during follow-up you continue to have metabolic syndrome criteria independent of weight? So if you look at the top line were individuals that have metabolic syndrome at the beginning of the study, at baseline, but then did not have it at follow-up. And the middle one was the ones that, I'm sorry, the one on top, they didn't have it at baseline and they didn't have it at follow-up. The line in the middle are people that had metabolic syndrome at the beginning of the study, but then lost it because of weight loss. And then the continuous line are the ones that they continue to have metabolic syndrome at baseline and throughout follow-up. In those individuals, their asthma control did not improve as much as the other two groups. And in fact, this group was 92% higher of losing asthma control compared to the other group. Suggesting that this is, by the way, these Cox models are adjusted for weight loss, for BMI loss. So suggesting the fact that it's just not about weight loss, it's about weight loss and improving your metabolic health. So I'm going to talk a little bit about some of the novel mechanistic pathways linking metabolism with airway dysfunction, inflammation, and asthma, particularly in the adult ones. Sweden published a paper long time ago now, in 2000 subjects, and found strikingly that subjects who were obese, and particularly subjects that were wheezing, had lower nitric oxide, which seemed to me like that did not make sense. Did not make sense. Why would in the world something that predicts airway inflammation be associated with disease severity in obese asthmatics? And so we published a study around the same time with Susma Chris, who's now an attending associate professor now at Emory University, in 67 asthmatics. And we asked the question, what is the relationship between BMI and nitric oxide? And what we found, and Paul and I were talking last night, that sometimes the best hypotheses are when you actually find the opposite you were trying to find. So when I did this study, I thought it's going to be very simple. Obese subjects are going to have higher nitric oxide, and it's going to be great, and it's going to get me a publication, and it's going to be all set. And in fact, I was like, remember when I look at these results, it's like, what the hell is going on? And we recoded it, make sure everything was fine, and no, these were the results. And what we found is that there was an inverse relationship between increasing BMI and exhaled nitric oxide. But at the same time, what we found is that with increasing BMI, these subjects had higher levels of 8-isoprostans, which is a lipid of peroxidation. So they had increased airway oxidative stress with reduced nitric oxide. I'm not going to bore you with a lot of pathways, but I think it's important to walk you through this one. So this result, honestly, this result has shaped the last 12 years of my career. I've been like looking at this for a very long time because I was really, as an investigator, I was like, this is not a fluke. Something is making this happen. So this led us to focus on this particular pathway. So I'm just going to walk you through it. So as you all know, L-arginine in the airway epithelium through nitric oxide synthase 2 or INOS, inducible NOS, generates to citrulline and nitric oxide. And that's the way that in the vessel is eNOS, but there's also NOS. So the majority of the airway epithelium is produced by NOS2. And it's constitutively produced, but when you get infected, or when you have a pollen, as Paul's work has shown, with nitric oxide, the INOS gets upregulated, you produce a ton of nitric oxide. So L-arginine also goes through arginase pathway to generate ornithine and proline and polyamines and all these pathways that relate to remodeling and other inflammatory pathways. But arginine at the same time is a fascinating aspect of biology. When many proteins in your cells are undergoing catabolic degradation or catabolic processes, they actually get dimethylated. And once they get dimethylated, they get tagged for proteolysis. So that proteolysis generates these segments of proteins that are attached to a methyl compound, an arginine compound. These are called asymmetric dimethyl arginines. And there's 3 of them. And we all produce them in our lungs, and we produce them on our endothelial cells as well. And they're associated with cardiovascular disease and a bunch of different things. But one of the things that's fascinating about ADMA is that these products in the cell, which increase with oxidative stress and with obesity, uncouple NOS. And what that means is that nitric oxide enzyme is NOS2, instead of producing nitric oxide, starts to generate anion superoxide. So the same enzyme contributes to oxidative stress and produces less nitric oxide. And so this is the whole premise. So the data from Harmot, Erasmus here in SickKids in Toronto, and Scott showed that, in fact, if you look at ADMA, asymmetric dimethyl arginine, in sputum subjects with asthma is higher, and it's inversely related to nitric oxide, which makes sense because you're uncoupling the enzyme, you're producing less NO. In our cells on our patients, we do a lot of research bronchoscopies at our group. We found that obese subjects compared to other groups have increased arginase expression. These are unstimulated cells, just fresh airway epithelial cells, and they have reduced arginine bioavailability. So these cells are starving of arginine in a way, and they have increased arginase activity, and they have nice enzyme uncoupling. And the reality is that this explains why this is happening. What you're seeing here is the activity of nitric oxide in healthy, lean, obese, and obese subjects in airway epithelium and in platelets. I'll explain you why in platelets. But clearly you see that subjects with asthma that are lean and that are obese, nitric oxide synthase of healthy subjects is upregulated, it always is. And it produces more nitric oxide. But then when you look at the increase in NOx, which is nitric oxide, nitrites, and nitrates, only lean asthmatics increase their levels. If you look at that, obese asthmatics do not increase despite nitric oxide synthase being upregulated. And the reason is because the enzyme is uncoupled. But what's fascinating is that we saw this uncoupling occur both in platelets and in the airway epithelium. And I don't have time to show you that data, but the correlation between platelets and epithelium is almost perfect, which makes you think that this is the response to a systemic metabolic phenomenon. So then we went back and asked the question, well, this is very interesting, but the relationship between nitric oxide, BMI, does it make a difference whether you develop child onset asthma or late onset asthma? The data would suggest that it's only on late onset asthmatics, and indeed it does. This is data we published a while ago from SAR, looking at the log of nitric oxide, relation to BMI, and the orange dots are those with late onset asthma. By late onset asthma, I'm talking about people that develop the disease after the age of 12, because Sally and others have shown that the pubescence into early adulthood determines many of phenotypical and endotypical aspects we see in airways diseases. So it's not 18 to 12. But if you look at people that develop early onset asthma, there's no relationship. So again, this is a late onset phenomenon relationship. And in fact, when you look at the level of L-arginine and ADMA ratios, you look at those late onset disease, those who are obese have the lowest L-arginine to ADMA. So they have reduction of L-arginine, partly because arginine is activated, and they produce more ADMA. So you can see the same pattern on the early onset, but not as much as the late onset. And this relationship actually has implications to lung function. So this is a log of ADMA in sputum in a recent reanalysis that Megan from my group did on the ASthmaNet bar study. So these are people, these are all African American subjects. As published in the England Journal of Medicine in 2019. You can see that there's an inverse correlation between lung function and ADMA. And I think we have to prove it. But one of the facts is that ADMA potentially is uncoupling smaller airway bronchodilator mechanisms through loss of NO regulation. On our cohort study, we see also an inverse relationship between the log of L-arginine to ADMA. That is, if you have less arginine to ADMA, you have reduced lung function. In subjects with asthma, actually adjusted for confounders. But you can ask yourself that the problem, we talked about it last night, the problem with asthma is that we tend to do a lot of cross-sectional analysis. What happens to these factors longitudinally? Because we're eating a lot of things that have arginine, getting airway inflammation. And this study from Claudia Morris in Pittsburgh showed that, this is in kids and adolescents, showed that plasma arginine in subjects with asthma is lower than controls, and SARP found the same thing. And the arginine bioavailability is lower in subjects in control, and subjects have higher levels of arginine in plasma. So again, subjects with asthma, regardless of weight, they have low arginine and higher arginine levels, which is a marker of disease severity. But look at what happens during exacerbation, which I think is fascinating. This is day one of exacerbation and levels of discharge. So people, when they come in with an asthma exacerbation, plasma arginine is lower. When they get discharged, it recovers. Same thing, arginine bioavailability goes up at discharge, and the level of arginase dramatically drops in some of these patients after they get discharged, suggesting that when you get sick, some of these mechanisms upregulate. And so we did one of our cohort studies looked at longitudinal. I'm not going to go into this study particularly, but one of the things that we saw is that there's biomarkers of arginine metabolism do play a role with asthma severity and exacerbation. So what you're looking at is the relationship between having an exacerbation throughout the cohort study. You can look at the publication here. If you look at, this is fascinating because if you look at the LRG and ADMA average, it's protected, and it makes sense. When you have more arginine, you have less ADMA, should be good. But if you look at the variability of it, you look at the exposure, there's a standard deviation, not the mean, is very strongly predictable of exacerbations. And to me, what it reflects is the fact that this is just telling you that when people exacerbate, the levels of arginine and ADMA are constantly moving up and down. And this is why the same measure, you look at different metrics, tell you very different stuff. So we did a study trying to say, okay, how about, can you intervene on this pathway? There's something you can do on this pathway. So this is a study published now, right, pre-pandemic. Again, I'm just going to walk you through, obesity and asthma associated with reduced arginine and increased asymmetric diametric arginine. And so the idea is that giving citrulline, the airway epithelial cells take citrulline, they generate arginine, and you can sort of flip the ratio and recouple enzyme. So the idea is that you can prevent nozzle blocking, making sure that the cells produce more nitric oxide and less anion superoxide. So to do that as a proof of concept, we gave people 15 grams of citrulline per day for 2 weeks, and we measured it before and after. So these were all mostly females. BMI was 36 on this study. Most of them were adult onset, poorly controlled at baseline. Look at their exhaled nitric oxide. We did not screen for nitric oxide, but their exhaled nitric oxide was 16. Moderate impairment lung function and reduced bronchodilation capacity. And most of them on multiple therapies. So what we found is when you treat patients with citrulline, of course, you increase your plasma citrulline and you increase your LRG to ADMA quite a bit, which is really good to see. But also we saw that when you give people these doses from baseline to post-treatment, you increase your nitric oxide by about 4.5 parts per billion. And you improve, in this particular study, we improved asthma control almost by 0.5. Now, mind you, not, it's not a placebo study, so you have to take it with a big grain of salt. But what's interesting is that if you look at who made the best improvements in lung function, we saw a very different response in females and males. So females actually had significant improvement with citrulline and FEV1, and particularly those with late onset disease, but not males, for example, and not those with early onset disease. Now, again, this is a proof of concept study for people that will recruit at Duke and University of Colorado. But again, suggesting that there's something about females late onset disease, and maybe they're the ones that are going to respond. So that led to this R01 that it's about 2 patients shy of finishing. I keep calling my coordinators, we roll the last one, we roll the last one. But it almost seems that the last patient is always the hardest to get. We did a case crossover study. These patients were treated with L-citrulline and placebo, and they were crossover, the six-week washout into the opposite phase. And they underwent a bronchoscopy before treatment and after treatment to look at changes on airway epithelial cell enzymatic response to treatment. These are some of the outcomes, which I'll show some of them. Today, this is a blinded study, so we haven't unblinded it yet. But you can see that in one group, which is here's group A, the FeNO went by 7.2 parts per million, whereas group B did not. So we suspect that one group is citrulline. We know that that's about a marker of response. But one of the things I find it fascinating, and I was telling Paul, this is I think a small airways disease, is that we see already significant changes. This is about half the study population. We see significant changes in small airway resistance, significant reductions in small airway resistance, and we see very large improvements in airway reactants. If you think about airway reactants, think about the peripheral stiffness of the lung gets better basically. Which I think it's just a fascinating response. And made me happy to see when Ann Dixon, who's done a lot of work in asthma and obesity from Vermont, published this study that shows that people with asthma compared to obese controls have much higher airway reactants, and even more so if you do methacholine. And what's interesting is that patients with high reactants have more symptoms of cough, sputum, chest tightness, dyspnea, wheeze, and awakeness. And all of the patients with high reactants, 100% of them were women. So again, I think it goes something to sex, adult onset disease pathobiology. And this is a complicated slide just to show you that. I'm going to show you some new data that we just completed with Max Siebel's group at National Jewish, which I'm excited about, trying to understand different gene phenotypical expression characteristics in the airway of these asthmatics and asthmatics. So I'm going to just show you some of that data. So this is a volcano plot looking at differential gene expression on patients with obese asthma versus lean asthma. And you can see that it's quite a bit of upregulation of some genes in obese asthma, and some of them are downregulated, particularly in the enrichment analysis. Many of them have to do with interferon signaling, which I've mentioned before, apoptosis and immune system regulation, and Parkin has to do a lot of mitophagy processes. And I had mentioned to you before, as similar to the UBioFed study, we find that in this cohort of patients, in this group of patients, there's a high degree of T1 polarization based on these biomarkers, gene biomarkers. So this is a package that Max Siebel's group does as a sort of T1 gene phenotype, or phenotype. So much higher in obese asthmatics compared to lean asthmatics or the controls. And when you look at the gene set enrichment analysis, so we see compare obese to lean asthmatics that they really are strongly involving interferon inflammation, inflammatory responses around this pathway, especially STAT1. And one of the things I find really fascinating is that we see a very strong different response with mucus and squamous metaplasia. And looking at classical genes for some of these pathways, so we see quite a bit of epithelial remodeling in patients with obese asthma. And that may lead to the fact that some of these patients, for example, here you're seeing that the obese asthmatics, we get biopsy in all of these patients, and the obese asthmatics compared to lean asthmatics and their groups have a much stronger presence of squamous metaplasia markers. In this case, what you see here in the green is KRT5 and this PR3. So obese asthmatics compared to the other groups. So I think we're seeing that, yes, the airways are metabolically different, and I didn't have time, but there's a lot of differences in terms of mitochondrial bioenergetics and biology that are complicated, and there's changes in glycolysis that may impact how these patients respond to viruses. So it's a very broad implications. So I just brought you a little snaps of some of the work that we're doing. But as a concluding remark, is perhaps that I hope that I convince you that obesity is one of the most common comorbidities, affecting 40% of subjects with asthma. It's associated with increased exacerbation risk, worse symptoms, and reduced response to medications. Metabolic dysregulation, such as insulin resistance, dyslipidemia, or increase in abdominal GERD, can independently or synergistically with obesity worsen asthma morbidity. And dysregulation of the LR gene and hepatic oxide metabolism in the lung periphery is a potential pathophysiological mechanism in obese late-onset females with asthma. That's honestly yet to be proven, but I hope that the data, if not, the data shows other things we have to figure out, right? And then, lastly, I think the airway epithelium in obese asthmatics shows evidence of increased T1 immune polarization, which is really fascinating to me. And it may explain why some of these patients, particularly with insulin resistance, start to lose function all the time. I want to thank my group, coordinators, co-investigators. And many of these works done with a lot of different people, National Jewish, Colorado State University. Harmon, who's done all the RGN metabolism work for us, University of Pittsburgh and Mount Sinai, our funding that made this possible. Thank you.
Absolutely wonderful talk. Thank you very much, Fernando. We'll open it up again. I'll take the privilege of asking the first question, if I may. Why women with L-arginine metabolism? Is there any obvious reason why it's so obvious in women and much less obvious in men?
Well, if you look at, I mean, that paper that I showed you, the cardia study, when they looked at who develops asthma throughout lifespan, about 2/3 or more of the obese of asthma in women are associated with obesity, unlike men. So maybe because women gain more weight later onset, and that impacts the disease manifestation, and not so much in men. So I don't know exactly what's driving it, but it's a great question. We don't know. We really don't know. Everybody's going to blame it on hormones, but I think that's too simplistic, probably.
I think that was very interesting. To take it further, these patients, they're Th2 low, they're already obese and have insulin resistance, and then we go and give them prednisone.
Yeah.
So are we actually making them worse? I think particularly we see that they don't really respond. We have nothing else to give them. So they wheeze and we keep giving them prednisone.
Yeah.
Any thoughts?
No, I mean, it's frustrating. I think I experience that all the time, and I think we are making it worse. And these are patients that, when you treat them with biologicals, they respond, but to a lesser extent. You don't take away the full morbidity in these patients. So I don't know. We have a great way to go about it. People are examining now the roles of GLP-1 drugs, and so there's a study ongoing to look at GLP-1 effect on asthma. So we'll see. Be interested to see. My expectation is going to get better.
Fernando did imaging studies in children, these children with asthma. And I think he showed that there's actually visceral fat and adipose tissue deposited in the intestines, the airways,
Yes.
all that, and raising the possibility of mechanical obstruction from just purely fat. Do you think that plays a role in adults? Because I noticed that none of your studies actually did imaging.
Yeah, I don't think so, because what I see is that a lot of disease morbidity, but when you look at the degree of functional impairment or airway obstruction, it's not linear with it. And some of the iOS data would suggest that the disease is predominantly manifesting in the periphery. So I think it's my own bias is that I think it's a small airways disease in many of these patients, which is hard to treat, and we don't have. And I do dynamic CT scanning on some of these patients, and I see a tremendous amount of mosaicism, heterogeneity or expiratory flows that you don't see it on the PFTs.
Maybe just a comment to follow up on that. We did by a student, Ashutosh Takar, a master's student who, my group, we do xenon ventilation imaging. And we did unbiased cluster analysis of all of the severe asthma patients we've imaged here. And one of the clusters that came up just using ventilation features from the MRI aligned with all of these observations. So it was an obese, predominantly female cohort. What was interesting is that they had an absolutely normal ventilation, so no abnormalities.
Interesting.
Yeah. So, and we have the opportunity to discuss that a little bit more this afternoon.
Interesting. I love it. That's fascinating.
I also want to kind of related to what Dr. O'Brien was asking, but in terms of the association with female sex, do you think hormones have anything to do with that? Or have you looked at like pre and post menopause, if that has an effect? Because we personally have looked at a mild asthmatic cohort, and we don't find differences in like sex differences, and we also don't find sex differences between women on oral contraceptives and not. So, but we assume that that might be because they're just a more population. I'm just wondering if you.
Yeah, we're not doing things with hormones. I know that there's data both from Juan Celedon's group and Eric showing actually not so much around estrogens, but loss of androgen signaling in women that maybe a more important factor. And then Sally we published a paper from SARP showing that perimenopausal women have more severe disease. So, the disease of
increases in severity. So I think there are factors that are postmenopausal, including weight gain, that could affect disease severity. And I think that there's a degree in which hormones are involved, but nobody knows exactly the extent and how to intervene. So it becomes the easy to go explanation. But I don't know. I mean, everybody talks about the switch from boys and girls, and then later in life, what is the risk factors that are playing in hormones? But I don't think nobody knows exactly.
Just thank you for a great lecture. I don't see a lot of asthma patients, but I see a lot of pulmonary hypertension patients. And a phenotype that yesterday I saw 3 of them were middle-aged women who are obese, sometimes with BMIs greater than 50, who have some pulmonary vascular disease, like PVRs between 3 and 5, not that severe, but quite profoundly hypoxic, like in terms of in comparison to the compensatory impact, and remarkable mosaic attenuation, and they wheeze all the time.
Yeah.
So they've been labeled with asthma, they've trialed them, God knows how many different therapies, and it sort of fits this clinical phenotype. So phenotype, so sort of what you're describing, was like, how do we capture them? And I was thinking that CT would be a good way, because if you bring up the CAT scans, it's remarkable mosaic attenuation as you were describing. So I don't know if you see this pulmonary vascular component that intertwines with this as well in your patient population.
All the time. All the time, and we end up referring some of these patients to our pulmonary hypertension group, and they normally don't put them on because they also have preserved ejection fraction heart failure, and so it's a complex cardiovascular pulmonary phenomenon, and there's not very good treatments for them. So.
Do you think it's related to the endothelial dysfunction and nitric oxide that's driving this?
I think
I'd love to give them all citrulline.
I think it's a.
My drugs aren't working.
I think it's a possibility. So we'll just have to wait and see what the results show.
Is it any side effects from the doses you're using?
Yeah,
can you put those are the doses in the dietary manipulation?
No. You would have to eat. No, impossible. I mean, the highest concentration of citrulline is in watermelon. You would have to eat
Watermelon.
hundreds of watermelon. Yeah, I'm sorry, I forgot to mention that. The name is sandia in Spanish for watermelon. But no, it's a very high dose, and we actually came to that dose very arbitrarily because we wanted to give people the maximum dose possible because we've done an earlier study with 3 grams, which was negative, that would be tolerated. And there's some data in the literature that in same type of amino acids, 15 grams above that level, you get quite a bit of diarrhea. And then the renal conversion of citrulline to arginine is capped. So we decided that 15 grams would be, and that convinced reviewers because they had a lot of questions, why are you choosing 15 grams? And so was rather arbitrary. But yes, some people complain of, the most common complaints are lightheadedness, nausea, diarrhea. But usually it's transient and it doesn't, has not led to discontinuation of therapy. It's also something that's used to treat erectile dysfunction, that does.
Just to go further on Dr. Hemblay's question, well, we see a lot of asthma, not much pulmonary hypertension, so it's the other way around. But it happens to us very frequently in clinics that we are referred these first severe asthmatic patients who are obese, and they also have pulmonary hypertension, now OSA, etc. And many of them, after assessment, end up not being asthmatic at all, but having tracheobronchial malacia. That's something we see quite often. So we are never able to demonstrate verbal obstruction, but tracheobronchial malacia, like it's such an important tool for us.
No, Carmen, I'm glad you brought that up because many of these patients have excessive dynamic airway collapse, which is it's hard to diagnose, and it's a major problem in some patients. And I always wonder, my own bias is that something happens metabolically that affects the consistency, the rigidity of the airways. But that's a problem that I think no one has an understanding of what's going on. But as you look at patients. Well, we have a protocol in which we put them through if you have more than 70% collapse, we put them through a stent trial. And if you improve symptomatically, then you go to thoracic surgery and they plicate the trachea and they put a stent on the membranous part. Good results. It's a big surgery, though.
Yes.